Good evening, dear students. Welcome to you, Sri Rama Hospital, Jaggaipet online lectures. Today we are going to discuss about the cholecystitis, both acute and chronic. In the previous class, that means yesterday, there was abrupt termination of the class because of some software and technical problem. I was talking to you about examination of the liver. So now what I feel is, first of all, I will complete that and then I will go to this topic. Is it okay? Shall I begin with this topic or shall I go to the previous class remnant, that is examination of liver and spleen? Okay, I will show you a small video clip about examination of the abdomen, because examination of the abdomen is a long case given to you in examination. So all of you should know, first of all, the technique of abdominal examination. That's why I recorded one video showing the procedure of abdominal examination. So just follow that. You have to keep the patient in the table with both the lower limbs flexed at the hips and knees. Then you must stand on the right side of the patient. The patient must have a pillow under the head. Why? Because if you keep the neck flexed, the limbs flexed, then automatically the abdominal muscles will be relaxed. Our intention is to have a soft abdomen to palpate the abdominal organs or any lumps there. For that reason, you want to make it soft. So the softness can be achieved by passively flexing, not actively flexing. If you ask the patient to flex voluntarily without having a pillow, then there will be contraction of the abdominal muscles. That's why you make the patient rested comfortably on a pillow and ask the patient to flex the limbs, prefer the lower limbs. Then it will make the abdomen soft. Why? Why this posture makes the abdomen soft? Can you tell me? Can you tell me? Any muscle, when it's put to stretch, it goes into stiffness. When you relax it, then it will be soft. So we want to make the abdominal soft by this procedure. Okay. Then you do the general examination. Start examining from the head. First of all, have a general look whether the patient is dehydrated, whether the patient is having any loss of weight, whether looking very ill. So you note that point. Then you start examining from the eyes. So I am standing on the right side of the patient because I am right-handed, making the limbs flex. Ask the patient to look down towards your fingers, look for jaundice, then look for anemia, look for lymph nodal enlargement. Here itself, I am checking for the supraclavicular lymph node enlargement. The so-called Virchow node is situated between the two heads of the sternomastoid muscle. So that is one head. There is another head. So in between there is a groove. So in the depression, you keep your index finger, and by the side of it, you keep your thumb and try to lift the sternomastoid muscle. Underneath the sternomastoid muscle, you will find the lymph node. So examine on the right side, because out of 700 to 800 lymph nodes in the body, 300 lymph nodes are there in the neck itself. That's why you have to examine the cervical lymph nodes in every case. Examine the palms, nails, the tongue, then examine for the heart and lungs. Because she is a very old woman with a lot of weakness. So when the patient is turned to the other side for examination of the lungs, I am examining the spine also there, as well as I am examining for the loins. But those things should be done afterwards. That is for the pedal edema. You press over the shin of the tibia and see for any depression. After general examination, do the abdominal examination. Ask the patient to turn the head to the left side and ask her to open the mouth and take deep breath in and out. Then you examine the abdomen by inspection, palpation, percussion, and auscultation. So this is inspection. When the patient is taking breath, you see whether all the quadrants are moving with respiration equally or not. Patient should take the breath through the mouth, not through the nose. You can note here a small lump above the umbilicus. All the abdominal quadrants are moving freely with the respiration. There is no visible peristalsis. There is no visible pulsations. Skin is looking dehydrated, inelastic, dry. Abdomen is scaphoid. Then you have to look for hernial orifices. Because she is a female patient, I have not videographed the hernial orifices. Then you examine the abdomen. When you examine the abdomen, what you must do is you have to ask the patient to take deep breath in and out. When the patient is taking breath, the abdominal wall bulges outwards. So then at that time, don't apply any pressure by your hand. Allow your hand to be lifted along with the abdominal wall upwards. Then the patient takes expiration. When the patient is taking expiration, the abdominal wall goes inside. So during that time, you take the opportunity to palpate the internal structures. So how you have to palpate is, you have to palpate it in the form of rolling. You should not punch it. If you poke it or punch it, then there will be reflex spasm of the abdominal muscles. So to prevent that, what you do is you just place your fingers over the abdomen and roll them. When the patient is taking expiration, what happens is the abdominal wall goes inside. Then you roll. By rolling mechanism, you feel for any lump or any tenderness, and also observe for any rigidity. She is complaining of pain there. That means there is some tenderness there. Keep a watch on the face so that when the patient winces, you can notice that there is some tenderness. When the patient complains of tenderness in the right hypochondrial region, then you must check for intercostal tenderness also. There is epigastrium. I am feeling the lump consistency, borders, mobility. I am feeling for the spleen. Mild spleen megaly you can palpate by this particular procedure. That means keep your left hand over the chest wall at the left above the left costal margin. Just slide it so that the skin will come more towards the abdomen. Then insinuate your fingers of the right hand deep under the costal margin. So you will be able to feel the tip of the deep inspiration. So by keeping your hand like that, you have to ask the patient to take deep inspiration. Then your hand will be touched by the spleen. Then you can know whether the spleen is enlarged or not. Normal spleen is not palpable. When a spleen is palpable, or the spleen to be palpable, how much size it should be? How much enlargement it should have? Tell me. Double. Yes, it is said that is at least double the size. The spleen should be there. Yes, nearly 2 times. Exactly not 2 times, nearly 2 times. You are right. Then feel the left lumbar region, left iliac fossa, suprapubic region. Then feel the umbilical region. The lump is there. That is why I'm trying to check for the plane of the swelling, whether it's parietal or so. Make the patient to raise the lower limbs straight. The abdominal wall becomes taut. Then you feel for the lump. The lump has become more prominent. In spite of the abdominal contraction, still you are seeing the lump. Then you have to do the percussion. Percussion for any free fluid. Percussion for the liver. A mass is felt here. Apart from the lump, what you are seeing, there is one more mass in the right hypochondrial region. That is why I am checking for the liver upper border dullness and continuation of the dullness of the mass with the liver dullness. So that is the lower border of the mass. So here is the costal margin, and here is the lump, and this lump is continuous with the liver dullness. It is moving down with respiration. That means it is a liver swelling. I am trying to mark the lower border of the lump. So it is a localized lump of the liver. That's why it is just only there for the right side. Yes, the other lump was identified during the palpation. The intercostal tenderness is checked in this case because this patient is having tenderness in the right hypochondrial region here. So when tenderness is there in the right hypochondrial region and a mass is felt, means it may be a liver mass and tenderness may be from the liver mass. So liver is mostly present under the thoracic cage. So you have to go for and check intercostal tenderness. So whenever there is tenderness is there in the intercostal region also, that means that the mass is nothing but a liver mass and it is tender on palpation. If tenderness is there in the intercostal region, you have to check for the tenderness both in the mid-axillary line, in the mid-clavicular line, as well as scapular line. If tenderness is there only in the mid-axillary line, that means that the patient is having a tenderness of the liver only for the segments 5 and 6 and 7. 6 and 7 are the segments that are involved with the disease. That is why it is having mid-axillary plane. If there is anterior, then it may be because of 5 and 8. If it is posterior scapular region, then again it may be due to 7 and 6. That is why you have to check for the intercostal tenderness whenever there is right hypochondric tenderness. Similarly, if left hypochondric tenderness is there, you have to check for renal tenderness as well as for intercostal tenderness on the left side. So auscultate for the bowel sounds. If any lump is there, auscultate over the lump. If a bruit is present for this lump, for example, what is your diagnosis? Tell me. If you hear a bruit, what is your inference? A lump in the abdomen, on auscultation, it gives a continuous murmur. So what is your inference? Over the lump, I am not talking that auscultation over the aorta. I am saying that when you auscultate over the lump, now the lump is in the right hypochondric region. So I am auscultating over the lump. So if we hear it breathe, yes, very good, it may be a hemangioma. Number two, AV fistula. Okay, there is AV malformation. Okay, very good. Any other thing? Can a neoplasm give a bruit? Yes, when? When do you get bruit over a neoplasm? When do you get a bruit over a neoplasm? Whenever it is highly vascular. Liver swellings, hepatocellular carcinoma is there. The hepatocellular carcinoma is one of the very vascular, it may be vascular. So if it is very vascular, then there will be, yes, because of neovascularization, then there will be a bruit. So whenever a lump is there, examine for the bruit over the lump. So this is the examination, but anyway, I will show you the liver examination and tell you. You start from the right iliac fossa. You start from the right iliac fossa with your index finger lying parallel to the right costal margin. So during expiration, press your hand down. During inspiration, allow your hand to rise along with the abdominal wall. As you reach the right hypochondric region, what you must do is you must apply pressure towards the cranial side of the patient. You must dip your hand and then push towards the right costal margin and see and examine while the patient is taking inspiration. Usually while taking inspiration, what I said is you allow your hand just to be lifted up. But here, when you reach the right hypochondric region, right costal margin, what you have to do is you keep your right hand with the right index finger parallel to the costal margin, and when the patient is taking inspiration, try to push it, so that because during inspiration liver will be coming down. So when you push your hands towards cranial side, you will encounter the margin of the liver that is slipping under your fingers. So you can notice here. This was, I have started examination on the right side, right iliac fossa. So with my index finger, I will try to feel for the lower part of the liver when the patient is taking inspiration. Of course, when the lump is uncounted, patient is complaining of pain also there. That is a painful and tender hepatomegaly. For the spleen, you have to start from here and go towards this left hypochondric side. You have to start from here and go in this direction. So this is the liver examination. So once the tenderness is there, you have to examine for the intercostal tenderness. Okay. Any doubts? I'll stop this video and we'll go to the topic of the gallbladder diseases. Any doubts, please? No. Okay. So for examination of liver, you start your examination from the right iliac fossa, go towards right hypochondric region. For palpation of the spleen, you start from right iliac fossa and go towards left hypochondric region. Even if there is increase in the size of the liver by 1 or 2 centimeters, the liver is palpable. In sthenic individuals, we have seen yesterday hypersthenic, sthenic, hyposthenic, and asthenic individuals. In the asthenic individuals, where the patient's habitus or body status is long and narrow, the liver is slightly palpable. In hypersthenic individuals, where they are broad, the liver is slightly at a higher level. It will be about 1 or 2 centimeters above the level of right costal margin. That is why usually the liver is not palpable. It is palpable only in slender and long individuals who are having the asthenic personalities. So if the liver is palpable means it is abnormal. In this patient whom we have examined just now, the cause of the hepatomegaly is because of hepatocellular carcinoma. And the cause of the lump just above the umbilicus is because of the supraumbilical hernia or paraumbilical hernia. The anatomy of the gallbladder. Let us see the anatomy of the gallbladder as well as the biliary tract. This is the right lobe of the liver. This is the falciform ligament. Here is the left lobe of the liver. This is the lesser curvature. Sorry, this is lesser curvature, and here is the lesser momentum, and this is the stomach, and here is the transverse colon. So the liver hangs over the pylorus, hepatic flexure of the colon, and part of the lesser momentum is also hidden under the lobe of the liver. Liver actually, the undersurface of the liver is not like this. The liver will be like this. So you are seeing the anterior surface like this. So actually this is the anterior superior surface. The inferior border is oblique like this. It is not horizontal. It is oblique like this. Sorry, it is oblique like this. So to look for the things that are there on the undersurface of the liver, you have to put a retractor and retract it up. Then you will see the undersurface of the liver. So like that here also we will just lift the lower part of the liver and see. You can see the retracts are there. The liver is retracted up. Now you can see on the undersurface of the liver. Now you can see the whole of the stomach, whole of the lesser momentum with its free border. Just under the free border, you can see the foramen of Winslow. Here is the pylorus and duodenum first part, duodenum second part, upper pole of the kidney, and hepatic flexure. This is the undersurface of the liver. Here is the spleen on the left side of the stomach, just below the liver. And you can see the gallbladder. So this is a very beautiful picture taken from Netter's anatomy. And the bile ducts and the portal triad structures, they are hidden by the cover of lesser momentum. This is lesser momentum. This is the free border of the lesser momentum. At the free border of the lesser momentum, these structures, portal triad structures, are covered by the lesser momentum on both sides. So the extreme free border is having these portal triad structures. Can you tell me how the portal triad structures are arranged? The portal triad means three structures are there. In one of the previous classes, we have discussed about that. What are they? Portal triad means what are they? What are the structures? Portal vein, bile duct, and hepatic artery. Very good. Very good. So bile duct, hepatic artery, and portal vein. So out of these three, how they are placed? Two structures are there anteriorly, and one structure is there behind. So two are there anteriorly, one is there behind. So out of these two, which is to the right, which is to the left? Anterior hepatic artery and bile duct. It is not portal vein. Then to the right, what is structure? Hepatic artery right? No, it is wrong. Hepatic artery right? No, wrong. Yes. Bile duct is to the right. Very good. Bile duct is to the right. Hepatic artery to the left. Behind these two structures lie the portal vein. Portal vein will be there on the back side. How to remember that? Duct is dexterous. Dexterous means to the right side. So duct is dexterous. If you remember like that, you will never forget. Bile duct is to the right side. So duct is dexterous. Let's focus this particular area. Yes, right means medially. No, sorry, not medially. Right means laterally. Now you can see here. This is the duct. It to the right side. This is the right side of the patient. Spleen is left side of the patient. So duct is towards right side. Hepatic artery is to the left side. And behind these two structures is the portal vein. Portal vein is a very big structure. Its diameter is more than the diameter of both the duct and artery put together. So it has such a big diameter. So this is the duct structure. This is the hepatic artery. Hepatic artery comes from the aorta. You can see the aorta here. It comes from the aorta. It comes straight like that horizontally, then turns upwards. It turns upwards and then divides into two branches near the porta hepatis. This is the porta hepatis or hilum of the liver. In the hilum of the liver, it divides into two branches, the right hepatic artery and left hepatic artery. And left hepatic artery divides again into four branches. Right hepatic artery divides into four branches inside the liver parenchyma. Sometimes these branches may be seen outside also sometimes. And yes, hepatic artery comes from celiac axis. Is one of the branches of celiac axis. The other branches being, you can see here, another branch is coming like this and going like this. This is the splenic artery. And another branch is going like this, going upwards. That is the left gastric artery. So three branches. One is hepatic artery, other is splenic artery, third one is the left gastric artery. Out of these three, left gastric is small. The hepatic and splenic arteries are quite big in size. Here you can see one more artery coming from the hepatic artery. What is this? An artery is coming down, going down. Yes, very good. Gastroduodenal artery. Wonderful. This is gastroduodenal artery. Okay, this is about the hepatic artery. Now, bile duct. Bile duct also start with from the liver, hilum, right and left hepatic ducts. They join together and form the common hepatic ducts. The common hepatic duct is joined by the cystic duct coming from the gallbladder. After joining of the cystic duct, now this duct is called as the common bile duct. Up to here it is common hepatic duct. From here it is called the common bile duct. Common bile duct is having four parts. One is supraduodenal portion, retroduodenal portion, infraduodenal portion, and fourth one is the intramural part. That small 1 or half centimeter length of the duct which is passing through the wall of the duodenum is called the intramural part, and it terminates at the papilla of the vater. It joins the pancreas duct before entering onto the papilla of vater. It is surrounded by sphincter of Oddi. So these structures, the portal vein, the hepatic artery, the bile duct, they are covered by the lesser momentum, free edge of the lesser momentum. Behind the lesser momentum, at the free border, you can see the foramen of Winslow. You can pass exactly, your index finger can be passed through this foramen. This is the sphincter of Oddi and papilla of vater. This is the common channel. This is of course showing the portal hepatis. Sorry, this is the portal triad. This is the stomach, and this is lesser momentum. Here is the foramen of Winslow. This is the lesser sac. The gallbladder has a capacity of about 50 ml. It has fundus, the body, and neck. There is a dilated portion on the ventral side of the gallbladder near the neck. This is called the infundibulum or Hartmann's pouch. And this is the cystic duct. The duct is having folds of mucosa that is called the valves of Hester. And cystic duct is surrounded by a sphincter of Lutkin. And here is the portal vein. The interior of the gallbladder has minute depressions. These are called the crypts of Luschka. These crypts of Luschka are the originating places for the caliculi, because some amount of bile will stagnate here, and from that stagnated bile, the caliculi can develop there. And this is the lesser momentum. This is free body of lesser momentum. So one of your colleagues just now asked me to describe foramen of Winslow again. So that is why I'll go to the previous slide. This is the free body of the lesser momentum. Now we can see here, under the surface of the liver, this is the anterior boundary of the porta hepatis. And behind the porta hepatis, just below the porta hepatis, you can find the free body of the lesser momentum. If you pass your finger just behind the free body of lesser momentum, your finger can pass in easily. Your finger will pass like this. That means your finger will pass between the portal triad structures in front, and behind lies the inferior vena cava. Here is the inferior vena cava, and these structures are there anteriorly. So in between there is a space. Through this space, you can pass your finger, and your finger can pass in freely up to the hilum of the spleen. So up to this whole thing is completely free. That is called the lesser sac. So the foramen of Winslow is bounded anteriorly by the lesser momentum free border containing portal triad structures. Posteriorly, it is having the inferior vena cava. Below, the upper border of the first part of the duodenum. Above, it is bounded by the lower surface of the or under surface of the liver. To the right, there is upper pole of the kidney and subphrenic space. Subphrenic space means if you just allow the liver to fall forwards, you will find a space between the liver and kidney here. This is called the hepatorenal pouch of Morrison. So hepatorenal pouch of Morrison will be in continuation with this foramen of Winslow. If you go from the Morrison's pouch, your finger can go directly into the foramen of Winslow, and you can go into lesser sac. So lesser sac communicates with the Morrison's pouch through foramen of Winslow. To the left of the foramen of Winslow is the lesser sac. Is it clear, doctor? Do you want any more information about this foramen of Winslow? Okay. This is cross-section view. So this is the free body of lesser momentum. This is the lesser momentum. And here you can see the pancreas. And of course, here will be the inferior vena cava. Behind the pancreas, you will find the inferior vena cava. Yes, foramen of Winslow is called as the communicating channel between the greater sac of the peritoneum and lesser sac of the peritoneum. Occasionally, small bowel can pass into this. When small bowel passes into this, then there will be internal herniation. Now this is the hepatic artery coming from the celiac axis. It comes like this. Already I told you about this. Here you can see the right hepatic artery gives off a branch behind the common bile duct. The hepatic artery goes behind the common hepatic duct, and it gives off a branch to the gallbladder. That is called the cystic artery. Cystic artery divides into the anterior and posterior branches. And from this hepatic artery, you can see descending branches coming along the bile duct. These are called the choledochal arteries, right and left. So the blood supply to the gallbladder is from cystic artery, which is a branch from right hepatic artery. So please remember that. These are some of the important points which are asked frequently in the short notes questions in the examination. Lymphatic drainage. The lymph from the gallbladder mainly drains to a lymph node situated in the Y junction of cystic duct and common hepatic duct. This is called lymph node of Lund. This lymph node is very constantly present over the upper border of the cystic duct. In the operation of cholecystectomy, if you find it difficult to identify the cystic ducts, then you look for this particular lymph node. If a lymph node is found means, then in the vicinity of the lymph node, you will find the duct, cystic duct. The lymph from the lymph node alone will drain into the hilum of the liver and join with the liver lymphatics and drain into the celiac group of lymph nodes. And some of them, they travel along the hepatic veins and go to the lymph node situated on under surface of the dome of the diaphragm. Gallbladder is situated in the gallbladder fossa. You can see, if you remove the gallbladder, you can see a small depression in the liver. That's called gallbladder fossa. On the inferior surface of the stomach, inferior surface of the right lobe of the liver, covered with peritoneum of the inferior surface of the liver. Actually, the peritoneum of the undersurface of the liver, it also covers the gallbladder. That is how gallbladder is bound to the liver. If you want to remove the gallbladder, you have to cut this edge of the peritoneum, which goes from the liver to the gallbladder. So if you can cut away this one, then there will be mild attachment with fibrous tissue and small blood vessels. So if you cut those structures, then gallbladder can be freed from the undersurface of the liver. Parts: fundus, body, infundibulum, neck, and cystic duct. This infundibulum is also called as the Hartmann's pouch. Blood supply: cystic artery, a branch of the right hepatic artery. Lymphatic drainage: cystic dome of Lund, nodes at porta hepatis, celiac nodes, and lymphatics of the liver. Callus triangle and cholecystohepatic triangle. So this is the one which you must be very thorough. It is asked many number of times in the PG entrance examinations as well as a short notes question in the theory examination. And of course, in the clinicals also, the examiners, they are fond of this particular callus triangle. What is this callus triangle? This is the hepatic duct, and this is the cystic duct, and here is the liver. So there is a triangle between the cystic duct laterally, hepatic duct medially, and above the undersurface of the liver. So the triangle made between these three is called the callus triangle. Originally, Callet, an anatomist, described not this triangle as this triangle. Of course, the contents of this triangle being right hepatic artery, cystic node of Lund. This is the triangle described by Callet. The boundaries of the triangle which were described by Callet are above the upper border of the cystic artery, the medial border of the hepatic duct, the lateral border of the cystic duct. So this is the callus triangle, originally described. But later, many of the surgical textbooks, they started describing callus triangle as having the inferior border of the liver at the inferior surface of the liver at the superior border of the callus triangle. Why means, in surgery, if you take this triangle, then that will be very practicable to search for the structures in the callus triangle. The one which is described by Callet is sometimes not practicable for certain things. So the more convenient thing will be to call this as the callus triangle. That is why if you just see the previous editions of Bailey and Lowe, so in one edition it is given as the callus triangle is the original callus triangle. In another edition, the one which I said, that is the right lobe liver undersurface at the upper border, is given as the Callus triangle. But the recent edition, the 17th edition, has given the clarity about the Callus triangle. Just I will show it in the next slide. In chronic inflammation of the gallbladder, this Callus triangle is obscured by thick fibrosis because of chronic inflammation. So this triangle is obliterated by inflammatory tissue, so you will not be able to find these structures clearly. Callus describes a triangle as a triangle formed by the superior border of the cystic artery, inferior border of the cystic duct. So this is the superior border of the cystic artery. Then inferior border of the cystic duct or lateral border of cystic duct. And medial border of the common bile duct. Medial border common hepatic duct. That means these ducts are also included in the triangle. It is not across from the superior border of the cystic artery, then lateral border of the cystic duct, and medial border of the common hepatic duct. So this triangle is Callus triangle. This is the original Callus triangle. In the contemporary literature, it is modified as superior border is inferior surface of the liver. That means this is the superior border. Medial is the common hepatic duct. So this is medial is the common hepatic duct. Lateral cystic duct and gallbladder. That means this is cystic duct. Then this is the gallbladder. So gallbladder also is part of the Callus triangle. This triangle contains cystic artery, right hepatic artery, and of course lymph node of Lund. I hope this is clear to you. There is no confusion now. Is this clear? Okay. You can expect this question in the examination at any time. This is one of the very frequently asked questions in the examination. So you must all be thorough with this. So this is the Callus triangle. Yes, when you are asked to tell about Callus triangle, what you must tell is, you must tell the inferior border of the liver. And sometimes the world examiners, they may be under the impression that cystic artery is the boundary, not the inferior surface of the liver. Then if the examiner knows only that particular point, then you may lose the marks. That is why it is better to specify that in the contemporary literature it is modified as. So this statement also, if you give it, then there will not be any problem. So that we mentioned both triangles. The original Callus triangle, then modified Callus triangle. Both you mentioned. Then there will not be any problem. In the operation of cholecystectomy, the boundaries and contents of this triangle have to be displayed first to safeguard the bile duct. So in the surgery of cholecystectomy, the first thing what you do is you display the boundaries. What are the boundaries? Cystic duct and gallbladder on one side, undersurface of the liver on one side, and hepatic duct on one side. If you can make out these boundaries clearly well, and the space in between these three boundaries, if you can dissect it clearly, then you can demonstrate the cystic artery, the lymph node, the cystic duct clearly. What is surgery of cholecystectomy is very simple. If you can identify these structures, put a ligature here and cut it, ligature here and cut it, separate the gallbladder from undersurface of the liver, the surgery is over. Only 3 steps. In chronic cholecystitis, this triangle is obscured by fibrosis and the structures have to be carefully dissected while performing cholecystectomy operation. Surface anatomy of the gallbladder, there are 2 methods. Number 1 is, if you follow the outer border of the rectus abdominis muscle, that is the linea subulionaris, that is spicelian border. So if you trace the spicelian border, where it crosses the right costal margin, at that place the gallbladder is situated. Or the other way is, you draw a line across the anterior superior spine on the left side, the umbilicus. So you continue the line upwards across the right costal margin. That goes where it crosses the right costal margin, that is the place of the gallbladder. That is a normal gallbladder bile duct. Like this, we don't see in all the patients. It is of various anomalies are there. So when anomalies are there, that will confuse the surgeon, and that surgeon may ligate one for the other. Instead of cystic duct, he may ligate right hepatic duct or even common hepatic duct. Instead of ligating cystic artery, he may ligate right hepatic artery. So these dangers are there. That's why you should know about these anomalies. Here you can see two gallbladders, two cystic ducts. Here is the gallbladder with a diverticulum. Gallbladder with multiple septae. Here the gallbladder is having a diverticulum at the fundus or a septa at the fundus. It looks as if the gallbladder is wearing a cap. This is called the Frisian cap. Because in the country called Frisia, in the olden days, there used to be a country called Frisia in the Asia Minor. So there the people used to wear such type of caps. Then it may have two cystic ducts. So if you identify only one duct and ligate one duct, then the other duct will be intact. So if you don't put a ligature here, it gets torn while you're doing surgery. And from that, the bile will leak. And post-operative patient will have biliary peritonitis. In this anomaly, the cystic duct joins the right hepatic duct, not the common hepatic duct. So it joins the right hepatic duct. So then you may be in trouble sometimes. Here you can see the gallbladder gets an additional duct from the liver. So these are the ducts in the liver. So the liver gives off a duct. Then this is called the cholecysto, that means gallbladder. Cyst means bladder. Chole means bile. Gallbladder, cholecysto hepatic duct. That means this is going to join the one of the branches of the hepatic duct. That is called the cholecysto hepatic duct. Unless you identify this one, if you are doing surgery for the cholecystectomy and removing the gallbladder from the gallbladder fossa of the liver, you are likely to tear it off. When it's torn, then what will happen? There will be oozing of bile and again bile peritonitis. So if you put a ligature, that problem will not be there. Then the cystic duct is having very long cystic duct. It goes and joins the common hepatic duct just behind the pancreas before it enters into the pancreatic duct, joins the pancreatic duct. So when such a long duct is there, you are likely to leave behind a part of it. So this part of it will again act like a gallbladder later, and the patient may develop stones here also, post-operatively. That's why you should not leave behind any remnant of the cystic duct. Sometimes the cystic duct may normally it joins on the right border of the common hepatic duct. But here you can see the common hepatic duct it crosses the common hepatic duct, again goes behind it, and joins the common hepatic duct somewhere down. So this again poses a lot of danger to the common bile duct. Then these are the anomalies with the arteries. The right hepatic artery goes straight on the left side of the common hepatic duct. Sometimes what happens, it turns and crosses in front of the hepatic duct, forming a loop here, and goes afterwards normally. So this is something like a caterpillar appearance. This is called the caterpillar hepatic artery. This is also called as Moynihan's hump. It's called the Moynihan's hump. So when this hump is there, this hump is at the junction of the cystic duct with the hepatic duct. So when you are doing surgery for the gallbladder, this is the place where you put a ligature. So when you are doing dissection here, this artery may be accidentally damaged, causing profuse hemorrhage. and ischemia to the liver. That is why you must bear all these anomalies in mind while you are performing cholecystectomy operation. Sometimes the artery may cross hepatic artery, right hepatic artery branch may cross in front of the hepatic. Normally it should go behind, but sometimes it comes in front. And sometimes the right and left branches, they are separate from the beginning. The left hepatic artery arises from the aorta here, from the celiac axis. The right hepatic artery arises from superior mesenteric artery below and goes a separate vessel. So these two vessels are separate. So these two anomalies, the three anomalies can be there. Absent gallbladder, very rare. Frisian cap. Floating gallbladder. That means gallbladder with the mesentery is there, which makes it more liable for torsion. Double gallbladder, rare. One of the gallbladders may be intrahepatic. Cystitic insertion, already I told you. This is again sometimes the right hepatic artery may be like caterpillar. It goes over the cystic artery and gives a cystic artery, it goes over the cystic duct as tortuous vessel. And it gives a very short cystic artery branch here. So when you search in the callus triangle, you will not be able to make out cystic artery because it is very short. The right hepatic artery may be confused for cystic artery and it may be ligated, thinking that it is the cystic artery. This is also called Moynihan's hump or caterpillar hepatic artery. So this is another form of caterpillar hepatic artery. So this is again described here, the Moynihan's hump. Moynihan's hump is given now and then in the examination, theory examination. That is why I have mentioned it separately here. Tortuous caterpillar-like hepatic artery may course as follows. Number one, coursing in front of the original cystic duct, as here you can see. The hepatic artery is going like this. So it goes in front of the cystic duct origin. Or tortuous right hepatic artery with a short cystic artery, like this here. Right hepatic artery has become tortuous with a very short cystic artery. So this may be considered as the cystic artery. Function of the gallbladder: reservoir of bile, concentration of bile by 5 to 10 times, secretion of mucus approximately 20 ml per day. These are the functions of the gallbladder. Already shown this picture to you. The bile is secreted continuously from the liver. The sphincter of Oddi is always kept closed. So the bile, what it does is, it overflows through the cystic duct into the gallbladder, and gallbladder absorbs the water, sodium chloride, and few electrolytes. And the bile gets concentrated and stores there. So bile is stored in the gallbladder and concentrated in the gallbladder. And to it, some mucus also is added. Now, when the patient takes some fatty meal, the duodenal mucosa secretes cholecystokinin and pancreozymin. These will go and then stimulate the gallbladder to contract, and they relax the sphincter of Oddi. With that, the bile will be pumped into the duodenum. So this is the anatomy and physiology of the gallbladder. Now we will go to the topic of cholecystitis. Cholecystitis is nothing due to cholelithiasis. That is why we will discuss about cholelithiasis. Types of gallstones: cholesterol stones. Usually they are single. They are about 6 to 10%. Pigment stones, there are 2 to 5%. They are formed by calcium bilirubinate. Multiple black and small. Then mixed stones. they constitute about 80 to 90%. Majority of these stones are because of mixed stones. They are formed by calcium bilirubinate, phosphate, carbonate, palmitate, protein. In USA and Europe, 80% are cholesterol stones. So in our country, this is the statistics. But if you're appearing for an examination in the US or in Europe, then you must say cholesterol is the commonest stone. But an examination conducted in India means you must say mixed stone is the commonest stone. These are the various stones. You can see this is the cholesterol stone. The cut section is showing such a shiny, brilliant appearance. And you can see these are the pigment stones. And these hexagonal shaped structures, these are all the mixed stones. Cholesterol stone, usually solitary, oval or round in shape, usually 1.25 centimeters or larger in diameter, pale yellow in color and feebly translucent. It may be associated with mixed stones by causing obstruction and infection. You can see this is the cholesterol, pure cholesterol stone. Here also you can see this rounded ball is the cholesterol stone, but it is not appearing white, it is appearing yellowish because of bile pigment coating. Because of long standing in the gallbladder, it was coated with the bile pigment. So on long standing, the cholesterol stone will get outer layers of pigment. Sometimes even calcium phosphate, calcium carbonate. That means it gets the coating of a mixed stone. Sometimes it may be larger in the Hartmann's pouch, as in this case. This is the Hartmann's pouch area. So it larges and grows there, and causes obstruction. Because of obstruction, there will be stasis in the gallbladder. Because of stasis, there may be these stones. So these hexagonal shaped stones are all the mixed stones. When you see the cut section, it has such a brilliant, radiant, crystalline appearance. Usually it forms in static gallbladder. A mixture of pigment and cholesterol may form around the primary cholesterol stones. Now you can see that spherical stone which I have shown you in the previous image. So the cut section of that one. In the center you can see the white one, white brilliant radiating one. So this is the cholesterol stone. And outer layers you can see the pigment as well as cholesterol mixed together. So you can see a mixture of pigment and cholesterol. Then pigment stones. Types of pigment stones. Black stones, 20% of the pigment stones. They are composed of unconjugated bilirubin, calcium phosphate, and calcium bicarbonate. Associated with hemolytic disorders. So spherocytic anemia patients, children may have pigment stones in the gallbladder. They may be brown. Their composition is calcium bilirubinate, calcium palmitate, calcium stearate. They are rare in gallbladder but form as primary stones in common bile duct due to infected bile and stasis. They also form around biliary stents and parasites that are there in the bile ducts. Then mixed stones. They constitute around 80% of the gallstones in our country. Always multiple. They are faceted in shape. So you can see the faceted shape of the mixed stones. On section, they are laminated like this. So there will be lamellae in circular fashion. The central nucleus may contain bacteria or protein due to epithelial debris. Alternate layers of cholesterol and calcium bilirubinate or carbonate are deposited on the central nucleus. Miscellaneous features. The gallstones may contain additional features like air in the triradiate or biradiate fashion and gives rise to the characteristic shapes of Mercedes-Benz or seagull signs. Sometimes there may be gas entrapped in the caliculi, and that gas may give this shape. When you take an X-ray of the gallbladder area, you may find stones with this air showing as black shadows. Sometimes the lithogenic bile may not precipitate to form caliculi, but may form altered bile in the gallbladder, that is lime water bile. So sometimes the bile, which is going to form the stones, having a lot of calcium phosphate, still not form the stones. So it may look like something like that in the X-ray. This is called lime water bile. The gallbladder field is filled with mixture of calcium carbonate, calcium phosphate, which is of toothpaste-like consistency. Always occurs with chronic cholecystitis and cystic duct obstruction, seen as opacified gallbladder on plain X-ray. Pathogenesis of these stones. The possible causes of gallstones formation are metabolic, infective, and stasis. Metabolic cause. You take a jar, put some water in the jar, and put some fat. Even if you thoroughly mix them, they don't mix. The fat will be like a supernatant fluid over the water. Now what you do is, you add few drops of soap particles and now shake it. Now fat mixes with water. It doesn't dissolve, but fat and water molecules, they now become as a uniform suspension. Why? How it happened? Because of the soap. Similarly, cholesterol is a fat-soluble substance. It is a fatty substance. Bile is primarily a water-soluble substance. There is water, minerals, electrolytes, and some of the salts produced by the liver. So this cholesterol is secreted by the liver and transported in the bile and excreted into the intestines. The cholesterol has to come like that. Now the cholesterol is fatty, bile is water. So will they come as separate layers like that? No, they come as mixed uniform solution. How? So this is the card of liver cells. These are the cholesterol molecules secreted by the liver into the bile canaliculus. Already bile is there in the bile canaliculus. They do not mix one another. So they should form two layers, and they may cause fat embolus, and there may be obstructions in the bile duct. They may cause obstruction, but that never happens. Why? Because in solution, the bile, what happens is we have the bile containing bile salts. The cholesterol molecules are there. These are bile salts are something like the matchsticks. It has a rounded head with a stick-like rod. And each bile salt, when you examine, it is like this. It has a rounded head with a stick to it. The stick is hydrophobic. That means it attaches to the fat. This rounded spherical end is hydrophilic. That means it attaches to water. So it has an hydrophilic end and at the other side the hydrophobic end. So this bile salt acts as a medium to combine a water molecule with the fat molecule. So this is the cholesterol that will be in center. To it, this, all these sticks are attached. There will be about some 15 to 20 or 25. And this end, a water molecule will be there. So for each molecule of cholesterol, there will be about 20 to 25 molecules of water attached to it through the medium of the bile salts. So like that, the cholesterol is converted into small micelles. These micelles are nothing but the fusion of cholesterol molecule with water molecule through the medium of bile salt. So the bile contains such large number of micelles. Cholesterol and mixed stones. Cholesterol is excreted in the bile as it is not soluble in water. It is held in solution by the detergent action of the bile salts and phospholipids. Bile salts have a hydrophilic end which attaches to water molecule and hydrophobic end which attaches to cholesterol molecule. This aggregate is called the micelle. The normal ratio of bile salts to cholesterol is 25:1 and the critical level for precipitation is 13:1. If the bile salts to cholesterol ratio is less than 13:1, then few of the cholesterol molecules, they are not put into solution. So they are separated. So when they are separated, they will precipitate and form cholesterol crystals. Cholesterol crystals aggregate together to form cholesterol stones. That is how cholesterol stone is formed due to this metabolic theory. So why this ratio is altered? Whenever bile salts are decreased or whenever cholesterol is increased. Let us see the conditions. The cause for this altered ratio is due to either increased levels of cholesterol or decreased levels of the bile salts. Cholesterol increase in contraceptive usage, obese persons, patients taking clofibrates. Bile salts decrease in ileal bypass or resection, cholesterol therapy, etc. Now, I will just ask a question. Why in ileal bypass or ileal resection there is decreased bile salts? Of course, already I told this answer to you in the previous classes. Very good, very good, very good. Ileum is the site of bile salt absorption. There is a constant amount of bile salts in the body. They are not regularly or daily, they are not secreted. A constant amount of about 5 to 6 grams is there in the body. Liver always secretes it into the intestines. Then these bile salts are again reabsorbed from the ileum, goes to the liver through intrahepatic circulation, and again secreted. So like that, they will be going on, absorbed and circulated, absorbed and secreted. Like that, it will be going on like that. This is called intrahepatic circulation. If you cut the ileum, resect the ileum, or if you bypass the ileum by doing some anastomosis of the proximal ileum to the colon, then what happens? The food won't go across the ileum. So bile salts are not reabsorbed. So the bile salt pool decreases. When bile salt pool decreases, the secretion of bile salts into the bile decreases. So the ratio alters. That leads to cholesterol formation, cholesterol stone formation. This type of bile is called lithogenic bile. Bile acids and bile salts are all the same. Both are same. Bile acid means or bile salt means they are all same. Sodium taroglucate, sodium, one more salt is there. So the bile salt or bile acid means both are same. There is no difference between them. Then the metabolic theory for formation of pigment stones. Hypersaturation of bile with bilirubin, which occurs in hemolytic disorders, makes the bile pigments to precipitate beyond the saturation point, causing pigment stones. So in hemolytic diseases, there will be large quantities of bile pigment being produced, and that comes to the liver. So liver conjugates that and secretes into the bile. So bile is flooded with lot of this bilirubin, and this bilirubin, when becomes oversaturated, that can lead to the formation of the stones. Infection by bacteria like E. coli or parasites like Escherichia coli sinensis. Escherichia coli produces an enzyme called beta glucuronidase. Glucuronidase means ACE means enzyme. It is enzyme to break the glucuronide. So what is the glucuronide? Bilirubin monoglucuronide, bilirubin diglucuronide means what? What are these two substances? Bilirubin glucuronide and bilirubin diglucuronide means what? What forms of bilirubin are there? Very good. They are the conjugated bilirubin. Very good. So the unconjugated bilirubin comes to the liver. Liver produces glucuronidase enzyme. That enzyme combines the glucuronide to the tags the glucuronide to the bilirubin. Then bilirubin becomes monoglucuronide, bilirubin diglucuronide. Bilirubin diglucuronide and monoglucuronide are water-soluble substances. They are called the conjugated bilirubin. The unconjugated bilirubin is not water-soluble. So liver makes the unconjugated water-insoluble bilirubin to water-soluble glucuronide bilirubin. So now the E. coli infection, if it is there in the gallbladder, what it does is it produces an enzyme called glucuronidase that splits the bilirubin from the glucuronide. Then what happens to the bilirubin? It becomes unconjugated. Once it becomes unconjugated means it is insoluble in bile. So it precipitates and forms the calculi. So the conjugated bilirubin becomes unconjugated, that insoluble bilirubin. So this bilirubin precipitates and causes calculi. Some surgeons believe that central nucleus of the mixed stones is formed of a mucus plug originated from bacteria. Lord Moynihan has stated that a gallstone is a tombstone erected to the memory of the organisms within it. Stasis, obstruction or stasis in the gallbladder can lead to sludge formation. This can lead to stone formation. Causes pregnancy after truncal vagotomy and in patients receiving total parenteral nutrition. Abnormal emptying of the gallbladder contribute to formation of aggregation of nucleated crystals of cholesterol esters and form stones. So due to some reason, there is some abnormal emptying of the gallbladder. So gallbladder is unable to empty completely. Some amount of bile remains in the gallbladder after its contraction. So there will be residual bile. This residual bile is a static bile. So whenever stasis is there, its minerals, they precipitate out and they form crystals. So the cholesterol forms the crystals, and from that the stones will form. Hence, in a patient with cholelithiasis, if you just remove the gallstones, it will recur. You have to remove the gallbladder also, otherwise the stones will recur again. Clinical features of cholelithiasis. Occurrence, it is commonly seen in fatty, fertile, flatulent female of 50 years. So this is the usual Statement 5Fs. Fat, fertile, flatulent female of 50 is the classical patient of gallstone disease. But nowadays we can see in thin persons also, in infertile women also, flatulent dyspepsia may be there or may not be there. In males also you can find, it is seen in any age. In children also you can see these gallstones. But this is the statement telling about the common occurrence of the stones. It can occur in any age and any sex. They are rare in South Africa and South India, but nowadays we see a lot of cases in South India also. Clinical presentation depends whether the stones are present in the gallbladder, CBD, or in the intestines. They may present in the gallbladder. They may pass through the cystic duct and come into the common bile duct. Then they can give some manifestations because of their presence here. They may pass down to the intestines and there they can cause some symptoms. The clinical manifestations being, they are asymptomatic in about 85 to 90% of the patients. They manifest as acute cholecystitis. Acute cholecystitis can progress to gangrene of the gallbladder. Acute cholecystitis can lead to perforation and an abscess or peritonitis. Acute cholecystitis can lead to empyema or pus in the gallbladder. Chronic cholecystitis. So stones in the gallbladder can manifest as chronic cholecystitis. It can lead to mucosal of the gallbladder. It can lead to acute cholecystitis now and then, and it can lead to carcinoma of the gallbladder. So these are the manifestations when the stones are there in the gallbladder. Largely they are asymptomatic. They may manifest with acute cholecystitis and its sequelae, chronic cholecystitis and its sequelae, or as carcinoma. So these are only the pictures to show you various. When the stone is there in the common bile duct, it can produce cholestatic jaundice, or it can produce cholangitis, or acute pancreatitis. In the intestines, it can cause acute intestinal obstruction. How the stones pass into the intestines? It can pass through the common bile duct and pass through papilla of water and come into the intestines. In that case, the stones are very small in size. When they are coming out through papilla of water, means they are only of about 7 to 8 millimeters in diameter. So 7 to 8 millimeter diameter stones don't cause any harm. They come out in the feces. Sometimes what happens is, because of the presence of the stone here, the stone may adhere and attach itself to the duodenum. So the duodenum is densely adherent to the gallbladder. So through this adhesion, sometimes the stone can ulcerate and perforate into the duodenum. So now what is happening? There is a fistulous communication between the gallbladder and duodenum. What do you call this fistula? What is the name of this fistula? Cholecystoduodenal fistula. So through cholecystoduodenal fistula, a stone can perforate into the duodenum, and it is large enough. If it is large enough, it can cause duodenal obstruction or intestinal obstruction. Gallstones and associated diseases. Saint's triad. Gallstones, diverticulosis of the colon, and hiatus hernia. If three of them are present, then it's called as the Saint's triad. Each of these produce dyspeptic symptoms, and causes of dyspepsia should be evaluated before undertaking the patient for surgery of gallstones. Acute cholecystitis. In the previous class, we studied about pancreatitis. There I said that acute and chronic pancreatitis, both of them belong to only one disease but different phases. Cholecystitis also, acute and chronic cholecystitis belong to the same disease phenomena. Now and then there will be acute exacerbation, that is called the acute cholecystitis, and continuous mild pain will be there, then there is chronic cholecystitis. So both of them are two phases of one single disease. Types of acute cholecystitis: calicculous cholecystitis, that is common. Then acalicculous cholecystitis. It may be due to Salmonella typhi infection, Clostridium welchii infection, stress following major surgery, trauma, and burns, or critically ill patients. So due to severe stress or clostridial infection or salmonella infection, there can be gallbladder infection without acalicculus. It is called acalicculous cholecystitis. Before I proceed, one of your students has put a doubt here. Meniere's syndrome is the same as what we had just now discussed about the cholecystoduodenal fistula. So I am putting the same question to you all. Is Meniere's syndrome and cholecystoduodenal fistula same or different? And what is Meniere's syndrome? Not same, different. Very good. Very good. Both of them are the stones in the Hartmann pouch only. But in one case, if the stone goes into the duodenum, it is the cholecystoduodenal fistula. If the Hartmann's pouch stone goes into the common bile duct, it is Meniere's syndrome. This is the gallbladder, this is the Hartmann's pouch, this is the cystic duct. This is the cystic duct. This is the common hepatoid duct. And here is the duodenum. Now the stone is here. If the stone bulges to this side, then it comes like this, and the stone erodes into the common hepatoid duct and opens into the common hepatoid duct. So that is called the Meniere's syndrome. So it opens into the common hepatoid duct, it is the Meniere's syndrome. But the stone opens into the duodenum, then we call that as the cholecystoduodenal fistula with obstruction to the duodenum or obstruction to the small bowel, producing intestinal obstruction. So Meniere's syndrome and cholecystoduodenal fistula are both due to a stone in the Hartmann, a large stone in the Hartmann pouch causing pressure. One is causing pressure over the bile duct, the other is causing pressure over the duodenum. So that is the difference. Is it clear? Okay, good. So the most common form of cholecystitis is calculus cholecystitis. A rare form is called the acalculus. That means without calculus, cholecystitis can occur. This occurs usually in salmonella or typhoid infection, Clostridium welchii infection, then severe stress of the patient following any major surgery, trauma, and burns. They can develop cholecystitis, and also in critically ill patients. Yes, gallstone ileus means it is intestinal obstruction due to gallstone. You are right. That's right. Acute cholecystitis. What is the pathogenesis? Commonly, if the stone in the gallbladder comes and blocks the cystic duct, then that produces retention of bile in the gallbladder and causes inflammation followed by infection of the gallbladder. So this is the commonest cause. Rarely, calculus in the lumen of the gallbladder can cause chronic inflammation of the wall with acute exacerbations now and then. Secondary infection by Escherichia coli, Proteus, and other gram-negative organs occur later. Occasionally, infection may be due to gas-forming organisms, that's called Clostridium welchii and anaerobic streptococci. This can lead to emphysematous cholecystitis, that means cholecystitis with gas in the wall of the gallbladder. This may lead to an early perforation. So if you take an X-ray for this such patient, you can see all this gallbladder is having the gas. That's why it's showing as black shadow here. Normally, gallbladder is not seen on plain X-ray abdomen. If you're seeing like a black pear-shaped shadow here, means that is because of gas. The gas indicates that it is a severe emphysematous infection, so it's very dangerous. This is CT scan showing the gas around the gallbladder. Sequelae of acute cholecystitis. It may cause local peritonitis. That means the gallbladder is inflamed, the overlying abdominal wall is there, and peritoneum is here. So the gallbladder fundus you have seen, it's projecting from the undersurface of the liver. That is in contact with the peritoneum. So it can produce the inflammation of the parietal peritoneum here, in the right hypochondric region. That is local peritonitis. This peritonitis may resolve or may progress to general peritonitis. Then other sequelae of acute cholecystitis being, if the infection becomes severe, the wall becomes thin, it gets perforated, and again it leads to peritonitis. Or if the wall distends, stretches, then vascularity gets impeded, and that produces gangrene of the bowel, gangrene of the gallbladder, and that produces peritonitis. So you can see the gangrenous gallbladder. Sometimes cystic duct is blocked. Because of the blockage, there may be infection, and the whole contents of the gallbladder may become separated, and it becomes the empyema of the gallbladder. That means gallbladder with pus inside it. Acute cholecystitis incidence same as that of the cholelithiasis. That means females with usually obese women, multiparous women. As gallbladder is covered by visceral peritoneum. but gallbladder comes in contact with the anterior-abdominal wall when it is distended. So the infection from the gallbladder wall will spread to the surrounding parietal peritoneum. So suppose this is the liver, here is the gallbladder. The gallbladder is projecting from the liver like this. Gallbladder is projecting. This is the fundus of the gallbladder. This is in close contact with the parietal peritoneum anterior abdominal wall. So because both of them are contiguous, the infection spreads from the fundus of the gallbladder to the parietal peritoneum. That is how it spreads. Not that the overlying peritoneum is infected. Overlying peritoneum is only visceral peritoneum. You are right. If you get doubts like that, so like this, you please ask me. Don't conceal them in yourself. The disease usually manifests as acute exacerbation of chronic cholecystitis. Symptoms: acute severe pain in the epigastric region. Because it is a foregut structure, the patient complains of pain in the epigastrium, or right hypochondrium when overlying peritoneum is inflamed. Then the pain may radiate to the inferior angular scapula along the dermatome of T7 dermatome. So initially the patient gets pain in the epigastric region, but after few hours the overlying peritoneum of the abdominal wall is also inflamed. Then patient gets pain in the right hypochondric region, which is sharp, well localized. The epigastric pain is only as a discomfort. Then this pain will radiate to the back towards the inferior angle of the scapula. Sometimes it may radiate to the tip of the right shoulder. Why shoulder pain is there? Why is shoulder pain present? Why shoulder pain occurs? Irritation of the diaphragm. Good. Why irritation of diaphragm in cholecystitis? When the patient is lying down, the gallbladder contents exudates. The gallbladder exudates. They can flow over the liver, over the undersurface of the liver. Sorry, undersurface of the liver from the superior surface of the liver and collect under the diaphragm. So whenever shoulder pain is there, means that indicates that there are a lot of exudates are coming from the gallbladder. There will be reflex pyloric spasm, and stomach as a reflex mechanism, it manifests with nausea and vomiting. There will be pyrexia because of infection. Past history of pain may be present in many of the cases. On examination, you will find tenderness in the right hypochondric region in this region, and there will be guarding. I explained to you the meaning of guarding in the previous class. Hepatorenal pouch has a very little area of contact with the diaphragm. Mostly it is between the liver and the kidney. Very small area may be in contact, sometimes there may not be any contact. That contact also is there after the lateral side of the kidney. Please remind me about this again. I will show you the diagram again. The first diagram what I have shown you, the same diagram I will show you and explain you how the diaphragm can come in relationship. But that's only a very small area. Exudates, as they can collect in the Morrison's pouch also. There is hepatorenal pouch also can be the place for the collection of exudates from the gallbladder. Not only from the gallbladder, many of the exudates collected in the peritoneal cavity can collect in this hepatorenal pouch, and that is the commonest area of subphrenic abscess. So there will be tenderness and guarding in the right hypochondric region. If the patient is under your care, with your treatment, within 2 to 4 days, the inflammation subsides. Then when you examine, you will find a spherical mass in the right hypochondric region. This mass is nothing but the greater momentum which is there comes and covers this inflamed gallbladder so as to ward off the spreading infection. So because of that, a small tender lump will be formed in this region. So greater momentum is called as the policeman of the abdomen. So wherever some inflammation is there, to that area, the greater momentum goes and then it adheres there. That is how it causes warding of the infection. Differential diagnosis: all acute pain abdomens must be differentiated. The most common things to be considered are perforated peptic ulcer, acute pancreatitis, acute appendicitis, amoebic capsule of the liver, right renal pain due to calculus or pyelonephritis, and you should not forget about myocardial infarction. Inferior wall infarction of the myocardium can manifest as pain in the epigastrium or hypochondric region. So you must always consider in all upper abdominal cases in elderly persons to differentiate them from myocardial infarction. So an electrocardiogram is a must in every case of upper abdominal pain past 40 years of age. Investigations. So these are the investigations you have to do for any acute abdominal patient. This is not only about acute cholecystitis, acute appendicitis, acute pancreatitis, perforated duodenal ulcer, any acute pain. If the patient comes, you have to do these examinations. I will ask you this question afterwards also. Whenever we deal with any acute abdominal emergency, I will ask you what investigations you do. So please remember them. Urine examination for RBC and pus cells. That is the simplest test you do to exclude urinary tract infections and urinary tract diseases. Plain X-ray abdomen in erect posture to exclude pneumoperitoneum. That means air in the peritoneal cavity. Air in the peritoneal cavity indicates perforation of any hollow viscous in the abdominal cavity, like perforated duodenal ulcer or perforated ileal ulcer due to typhoid. Total leukocyte count. In all infective conditions, it is elevated. It is more than 11 or 12,000 per cubic millimeter. Serum amylase estimation to exclude acute pancreatitis. Then ultrasound scan of the abdomen to visualize the gallbladder and its contents. In some cases, you have to go for radionuclide scan, and other cases you have to go for CT and MRI scan. These two, the last two, are done only in special circumstances. So routinely for all the acute abdominal cases, these 5 tests are mandatory. Urine for micro, plain X-ray abdomen, total leukocyte count, serum amylase, ultrasound scan abdomen, and up to here. So these things must be done in every case. The other investigations like CT and MRI, they are reserved for certain other cases. Plain X-ray abdomen may show a gas-filled gallbladder. That indicates that it is emphysematous cholecystitis, which is very dangerous. Ultrasound scan of the abdomen that will show you the wall of the gallbladder. So this is the wall of the gallbladder. You are seeing 3 layers, one white layer, one black layer, and again one white layer. That means it shows as if it is having 2 walls. The white layers are called the walls. So it looks as if it is having two-layered wall. So whenever you see a double-layered wall of the gallbladder on ultrasound scan, that indicates that there is edema of the gallbladder wall. Whenever edema is there, the fluid gives the black coat like this. Because of the black coat, you are seeing two layers here. This is called double-walled gallbladder wall. This is very, 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 very suggestive of acute inflamed gallbladder. And you can find a hyperechoic round shadow here. And underneath that one, you find a shadow. So edematous gallbladder wall is seen as double-walled gallbladder with gallstones having acoustic shadowing. Tomorrow, when we're talking about the obstructive jaundice, I will tell you in detail about ultrasound scan, how to interpret the ultrasound scan. What is hyperechoic shadow, how is it produced, what is hypoechoic, what is isoechoic. So all these things I will describe you in the tomorrow's class. So in the obstructive jaundice, so the stone in the common bile duct will produce obstructive jaundice. So the investigations for obstructive jaundice we will discuss tomorrow. So there I will tell you in detail about this ultrasound scanning. If you already know about this ultrasound scanning and all that, of course, I can skip that particular slide. Do you need or not? Please tell me so that I can put the slides there. If you already know about that. Okay. Then I will explain. Majority of you want the ultrasound scan description, I will explain that. Very good. Okay. This is a radionuclide scan. The radionuclide scan shows that there will be excretion of this is all the liver. And you can see a small shadow here, there is a gallbladder under the liver. So normally, gallbladder shadow is seen after giving HIDA or PIPIDA scan. Now, in acute cholecystitis, the gallbladder is non-functional. That's why it can't take up the radionuclide, so you can't see the shadow here. Non-visualization gallbladder occurs in acute cholecystitis. CT scan, indication, suspicion of perforation, gangrene, spreading peritonitis. So whenever the pain, I told you, within 3 to 4 days of treatment, the pain subsides, tenderness decreases, guarding decreases, and you will be able to feel a small tender lump in the right hypochondric region. But when perforation, gangrene, or spreading infection occurs, the pain will increase, fever will increase, pulse rate increases, and total count increases. So when they are increasing, then that means that there is suspicion of these things. So whenever you suspect those things, you must ask the patient to have a CT scan. That will in detail tell you whether there is any perforation, gangrene, or spreading peritonitis. MRCP is done whenever there is a stone in the suspicion of the stone. That means if jaundice is there for the patient with the acute cholecystitis, then you have to do MRCP to know for location of any stone in the common bile duct. Treatment, it depends upon the condition of the patient and severity of the disease. We have seen the sequelae. Acute cholecystitis may produce gangrene, perforation, spreading peritonitis, abscess, etc., etc. Or it may be simple acute inflammation which may resolve with your treatment. So when the patient comes to you, what is general condition of the patient and what is severity of the disease? These two you have to assess. So basing on these things, there is a grading system that is called Tokyo grading for severity of the acute cholecystitis. Grade 3. If cholecystitis patient is having associated organ dysfunction, that means the patient has gone into general peritonitis. General peritonitis has produced systemic inflammatory response syndrome. Systemic inflammatory response syndrome has led to multiple organ dysfunction syndrome. So it has gone to SIDS. SIDS has led him to MODS. So there is multiple organ dysfunction. CVS, patient will be in hypotension requiring dopamine or noradrenaline. There may be neurological disturbance in form of altered level of consciousness. Respiratory system, there may be features of ARDS. Renal, the patient may be having renal failure in form of oliguria or elevated serum creatinine more than 2 milligrams percent. What is the normal serum creatinine level? What is the normal serum creatinine level? These things you must remember. They are very important. Yes, 0.8 to 1.2. That is the normal. .8 to 1.2 milligrams. That is the normal. Okay. If it's more than 2 milligrams, it indicates renal failure. Of course, if it's more than 1.2 or 1.3, you must suspect. Hepatic dysfunction is known as prothrombin time. The fate of emphysematous gallbladder is perforation, general peritonitis, and death of the patient if it is not dealt with in the very appropriate time. So once you identify it, you must immediately operate the patient and then remove the gallbladder. Otherwise, patient will die. The chance of death in about 95 to 99% of patients. Hepatic dysfunction is gauged by prothrombin time. The prothrombin time, it is having 1.5 times that of the internationalized normal ratio. Santi, I can't get your question. What under the diaphragm will you absorb? Gas. Yes, gas under the diaphragm is absorbed. No problem. There is no problem with gas. Gas in the gallbladder always indicates a severe anaerobic infection. Why it is severe anaerobic infection? Because the infection occurring due to an anaerobic organism, it spreads very rapidly, both systemically as well as locally. So it can lead to very high sequelae of systemic inflammatory response, and that can lead to multiple organ dysfunction because of the toxins as well as because of the inflammatory mediators. Hematological dysfunction in the form of platelet count less than 1 lakh per cubic millimeter. So this is platelet, this is prothrombin time. So grade 3 means it is associated with organ dysfunction. It can be cardiovascular, neurological, respiratory, renal, hepatic, or hematological. Grade 2 is moderate acute cholecystitis. In this, apart from cholecystitis, there will be total count of more than 18,000 per cubic millimeter, total count. Palpable mass in the right hypochondric region. Duration of the patient's illness is more than 72 hours. Marked local features of peritonitis. So there is severe guarding and guarding over a very wide area and high fever and high total leukocyte counts. So that indicates that there is some spreading local infection due to perforation gangrene, pericystic abscess, emphysematous cholecystitis, biliary peritonitis, or due to liver abscess. So, whenever you suspect these things, you must always act very rapidly. Grade 1 patients means there is cholecystitis, no organ dysfunction. Mild local signs of acute inflammation. There is no severe local inflammation. So, like that, you can grade the patient into 3 grades, and basing on these grades, you will manage the patient. So, management based upon Tokyo grading. Grade 1 patients. Just now we have seen there is no organ dysfunction. Patient is having only acute cholecystitis. In these patients, the treatment of choice is emergency cholecystectomy. If the following are present: patient has come to you within 5 to 7 days of onset of the pain, surgeon is experienced in doing cholecystectomies, operation theater has all the facilities to operate. So any emergency problem is there, there should be the adequate equipment for you to help you to come out of the situation. So when such is there, you have to go for emergency cholecystectomy. In acute inflammatory conditions, what will happen is the organ is very much congested due to acute inflammation, and it is very much edematous. All the edematous organs, when you hold them with the forceps, they come away. They will tear away. That means they are friable. So acute conditions, when you want to operate, means there will be high vascularity with lot of oozing and bleeding, and the organ is very friable. If you want to dissect, if you hold it and then pull it this side or that side, that organ tears away. That problem will be there. So unless surgeon is very experienced to hold the organ, so one should not go for emergency surgery on those cases. Then what you have to do, you go with the medical treatment, and after the medical treatment, this condition subsides, infection subsides. Then you give a period of about 5 to 6 weeks time, and then you operate and remove the gallbladder. When the gallbladder is quiescent and cool, when gallbladder is very hot, then don't touch it. It may burn. Unless you are very experienced, don't touch it. If the above are not fulfilled, conservative treatment followed by elective cholecystectomy after 6 weeks is the treatment of choice. This is for grade 1 patient. Grade 2 patients, that means localized inflammation is severe. You are suspecting some spreading infection due to perforation, emphysematous cholecystitis, abscess, gangrene, etc. So how do you deal with this? You have to do emergency surgery and cholecystectomy. If cholecystectomy is not feasible because of friable gallbladder, congested gallbladder, or callus triangle is very congested and you are not able to find out these ducts very freely, then cholecystostomy is considered. What is cholecystostomy? What is cholecystectomy? First tell me what is cholecystectomy. Cholecyst means gallbladder. Ectomy means removal. Cholecystectomy means gallbladder removal. What is cholecystostomy? Yes, very good. Putting a tube in the gallbladder and draining the contents of the gallbladder outside the skin. Cholecystostomy. Cholecysto means gallbladder. Ostomy means opening outside. Cholecystostomy means opening the gallbladder to outside by putting a tube. That's called cholecystostomy. So if the condition is favorable, go for cholecystectomy. If the condition is not favorable, just put a tube in the gallbladder, leave it outside. All the bile and infected X-rays, they will drain out. Give antibiotics and support treatment. The patient recovers. And then do cholecystectomy after 6 weeks when the patient condition has improved. So this is for the, sorry, this is not for grade 1, this is for grade 2. So for grade 2 patients, the treatment is emergency cholecystectomy. If not feasible, you have to go for the, sorry, there is grade 2 only. Okay. Then grade 3 patients, because they have organ dysfunction, resuscitation to manage organ dysfunction. You have to resuscitate the patient. Cardiac failure is there, you treat it. Respiratory failure is there, you treat it. Renal failure is there, acute dialysis. So like that, you manage the patient. Once the condition becomes stabilized, then you do cholecystostomy. That means you put a tube in the gallbladder by open procedure or by percutaneous needle cholecystostomy under image guidance. Under ultrasound guidance, you can pass a needle and a tube into the gallbladder directly, and you can aspirate the fluid and pus from the gallbladder, and you can relieve the patient for the time being. Then after 6 weeks, you can plan for an emergency surgery. After improvement of the condition of the patient, 6 weeks later, cholecystectomy can be done. In this condition, in this management, tube is left intact like that. Tube is left open and connect to a bag. All the fluid will be collecting there. So you keep it for 6 weeks. After 6 weeks, you remove the tube, do surgery, remove the gallbladder. Conservative treatment, that is a non-operative treatment. How do you do it? Just like a Foley, usually you put a Foley only. Conservative treatment, rest to the bowel, nothing by mouth, and nasogastric aspiration and intravenous fluids. You have to give them for 3 to 4 days. Analgesics to the patient, antibiotics, as the cystic duct is blocked in acute cholecystitis, those concentrated in serum are preferred, like ciprofloxacin, cefazolin, cefuroxime intravenously along with metronidazole. Monitor the progress to detect the general peritonitis. That means rising pulse rate, spreading pain, tenderness, and guarding, then leukocyte count. You have to examine daily these 3 things. If they are increasing, means the local peritonitis is spreading to general peritonitis. In 90% of the patients, the symptoms resolve with this conservative management. Conservative treatment is abundant in the middle in the following conditions. If the guarding and tenderness are spreading or increasing in spite of treatment, that means the patient is getting general peritonitis. Surgery is advised. That means these patients are going into grade 2. If pulse rate, temperature, total count, and CRP are increasing, that means these are general signs of infection are increasing. The nature of surgery depends upon the condition of the patient. So you may have to do cholecystectomy or cholecystostomy depending upon the gallbladder status. The patient is fit, you do cholecystectomy to remove the diseased gallbladder, which is the seat of stone formation. It is done by either laparoscopy method or by open method. So nowadays, laparoscopic cholecystectomy is the gold standard treatment for the gallbladder disease. So you ligate the cystic duct, ligate the cystic artery, separate the gallbladder from the gallbladder fossa, and then remove it. So cystic artery is ligated, gallbladder dissected from the liver bed. First, you make a window in the lesser sac to expose the callus triangle. Do we put a tube for acute cholecystitis? That is, if you want to do cholecystectomy, there is no need for a tube. If you want to do a cholecystostomy, then tube is placed in the gallbladder and left outside. No, it's not like that. Male or female, the difficulty in lap chole is not because of the gender of the patient. It is all depends upon the callus triangle, whether it is clearly seen or not. Number 2, the associated anomalies in the gallbladder, cystic duct, and bile ducts. They dictate whether surgery is difficult or easy. not the gender of the patient. So if the patient is fit, you go for cholecystectomy. If the condition is suitable, you go for cholecystectomy. Otherwise, you go for cholecystostomy. This is cholecystostomy. This is gallbladder. This is abdominal wall. You make a opening in the abdominal wall, put a Foley's catheter, inflate the balloon in the gallbladder, and leave it outside and connect it to a tube. Sorry, connect to a bag. So you are draining the gallbladder. So like this, put a Foley's tube, and then the patient is severely ill and in debilitating condition, who cannot withstand cholecystectomy, or the gallbladder is edematous and friable with obscured callus triangle, then cholecystostomy is done to drain the gallbladder after removal of the stones. Done by open surgery, laparoscopy, or by radiological percutaneous cholecystostomy. Cholecystectomy is performed later after the patient's condition improves. Once you let out all the X-ray collections in the gallbladder and remove the stone, then patient's inflammatory condition comes down. His general status improves. He takes normal diet. Then you can plan for cholecystectomy operation. This is how you do the cholecystostomy. The gallbladder is dilated, so you put a persisting suture, put a trocar cannula, empty the gallbladder, then insert a tube and tie the persisting stitch all around. Of course, after removal of the stones. Treatment of complications: if there is an A abscess, drain the abscess, do cholecystectomy or cholecystostomy depending upon the condition of the gallbladder and permissibility of the operation. Perforation, gangrene, or peritonitis is there. Laparotomy or laparoscopy, cholecystectomy, or cholecystostomy plus peritoneal toilet. That means peritoneal wash with 2 to 3 liters of ringer lactate solution. Chronic cholecystitis. Of course, in the tomorrow's class, we will discuss about chronic cholecystitis. Any doubts? Any doubts, please? No? Okay. If you have no doubts, means I will close the... Okay. You are asking about the hepatorenal pouch. I will show that one. It's very good. You have asked very good doubts. I come from the bottom one. Even if the infection resolves completely, then is there a need to do cholecystectomy? Yes, you have to do cholecystectomy because the inflamed gallbladder with stones inside the gallbladder will always be recurrent infection in 100% of the cases. And the next attack of infection will be more severe than the first one. That is why you must always try to remove the gallbladder as and when the condition favors. That is usually within 4 to 6 weeks' time. How the parietal peritoneum is infected? The parietal peritoneum is infected by the X-rays coming from the gallbladder. Suppose this is gallbladder. Here is the parietal peritoneum. By local adjacency, the X-rays will contact the anterior abdominal wall. That is why the peritoneum is infected. And also the X-rays pass down and pass right side, left side, down and medially, etc. All around the X-rays will be flowing. So wherever the X-rays go, there the peritoneum gets infected. That is how there is spreading peritonitis. To prevent that flow of fluid or X-rays all around, the great lumen which is nearby, it comes and wraps around the gallbladder, so that all the fluid will be loculated within the greater momentum. It won't spread outside. The spreading peritonitis is not because of simple irritation. It is because of inflammatory X-rays secreted by the inflamed and infected gallbladder. These inflammatory X-rays, they pass all around the gallbladder. They can flow down like this and collect in the hepatorenal pouch. They can flow down over the surface of the liver, and then they can pass under the dome of the diaphragm and can cause irritation of the diaphragm. They can pass downwards into the abdominal cavity and can cause generalized peritonitis. So all these things are because of the X-rays. The X-rays are too much X-rays will be there in case of complete obstruction of the cystic duct with distension of the gallbladder. If there is mild obstruction, the X-rays will be less. So if the X-rays are large, the general peritonitis also occurs very fast. So that is why you have to admit the patient and watch for tenderness and guarding, pulse rate, and total count. These 4 things are needed. If tenderness is spreading, guarding is spreading, pain is increasing, pulse rate at the time of admission is 110 per minute. The next day it has become 120. The third day it has become 150 or 160. Total count initially is 10,000. 2 days later it is 18,000 or 20,000 is there. That means there is definitely very rapidly spreading peritonitis, and that has to be operated immediately. If you can, you remove the gallbladder. If you can't remove it because of your less experience or because the gallbladder is very friable, put a tube in the gallbladder, let it out. That is called cystostomy. So do either ectomy or ostomy for the gallbladder. Something has to be done. Don't continue with the conservative management. I hope you got the message. Okay. Now this is about the the coronal ligament, superior coronal ligament will stop the flow over it. That is why superior coronal ligament is exactly at the place of the cupola of the diaphragm. The cupola of the diaphragm when it is irritated, the patient will get pain over the tip of the shoulder. That is why whenever tip of the shoulder is having the pain, means the fluid has collected at the cupola of the diaphragm, at the superior border of the liver. Now you can see here, this is the foramen of Winslow, and number 3, that is the place of the hepatorenal pouch. When the pus from the gallbladder or X-rays from the gallbladder, they flow like this. They collect here. From there, you can see from the lateral border of the kidney, they can pass like this. If they pass like this, here is the diaphragm. So this is the diaphragmatic area. So the Marston's pouch laterally under cover of the liver, it communicates with the diaphragm. To the left, it communicates with the lesser sac through foramen of Winslow. Now is it clear? If you see the coronal section, this is the liver. The lower part of the liver, lower surface of the liver actually inclined downwards and forwards like this. And here is the kidney. So this space is the hepatorenal space. And to this side is the diaphragm. So if you come lateral to the kidney, so by the side of the kidney, you have the diaphragm here. So the hepatorenal pouch is this one. So the fluid can come like this and can irritate the diaphragm here. I hope this is clear to you. Are there any more doubts? I will be happy to clear them. Lesser sac upper boundary. You can see this is the lesser sac. The sac behind the stomach. So this is the lesser sac. The upper boundary is the left lobe of the liver posterior to the portohepatis. So this is the upper border of the liver. This is the upper boundary of the lesser sac. Posterior border of the lesser sac is the aorta, then the pancreas. This is the pancreas. This is the posterior leaf of the greater momentum. Posterior leaf of the transverse mesocolon. Then greater momentum comes here. Yes, does Morrison pouch communicates with the paracolic gutter? It communicates with the right paracolic gutter very much. You can see here in the top diagram, this is the colon. By the side of the colon is the paracolic gutter. So the Morrison pouch fluid, it can come like this and track down in the paracolic gutter like this. Yes, you are right. It communicates with the right paracolic gutter. But usually what happens is, whenever pus accumulates in Morrison's pouch, there will be surrounding fibrinous adhesions because fibrin deposits all around. The fibrin encapsulates it. That's why though it communicates with all these structures, pus won't flow easily into the lesser sac, it won't drain into the paracolic gutter, it won't go into the posterior diaphragmatic space. So it is walled off by adhesions. If walling off is not there, then there will be diffuse peritonitis. The pus will be flowing all around and it causes a very diffuse peritonitis. Are there any more doubts? Okay. I will close this session and we'll meet again tomorrow at 4 p.m. You will not be given any more links. Whatever link that was sent to you yesterday, through the same link, you can join the classes for all these topics, for all the topics mentioned for topic 1. That means for cholecystitis, choledocholithiasis topics. If I change the topic, then you will get a link. Till I change the topic, for all these 3 days or 4 days or 5 days, whatever it is, till the topic is completed, no more links will come to your email ID. With the first link that is sent to you, to your email ID, that is the link with which you can access these classes. I hope I am clear. Greater momentum adhesions are also removed during surgery. Yes, very much. They cause a lot of problem during surgery. So you must always separate the duodenum, which is adherent, the greater momentum, which is adherent to the gallbladder, and you must remove them. The adhesions have to remove them, and then you have to do surgery. Okay, if you have no doubts, I will close this session and let's meet again tomorrow at 4 p.m. So you need not search for any email for the links. You can directly connect to this class by the link that is sent to you yesterday. Thank you. Wish you all good night. Bye.